Hi, everyone. Thank you for joining us for today's webinar on loss and wellness, supporting providers amidst the overdose epidemic. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar through a few different ways. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Adelya Urmanche, will take questions at the end of the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1 PCB and/or NADAC credit, which is free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificates to be available in your MyIRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you will receive a follow-up email which will include a link to an evaluation for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Adelya Urmanche is trained as a clinical psychologist and is finishing her postdoctoral research fellowship at Mount Sinai Beth Israel in New York City. She is interested in research that amplifies the voices of people who use drugs and those who work with them, directly informing clinical practice. She has previously worked with organizations like the New York City Department of Health and Mental Hygiene and Weill, I might not be saying that correctly, Cornell Medical College. Okay, Adelya, if you are ready, I will hand things over to you.
Thank you so much. It's so good to be here. And it's hard to say excited when we're talking about loss, but I am excited to have this conversation with folks. My experience in talking about this topic is that we don't talk about it, really. So that's partially why I'm excited to have this conversation. I obviously do have slides, and I'll go through my slides to share some of the literature that's out there around this particular loss, particularly for providers, and sort of some things that we can do in our community, as well as in our settings that we work in. However, I do want to leave a good chunk of time for discussion. I want people to engage, ask questions. I will keep an eye on the chat, but as Marla said, we'll get to the Q&A towards the end. So I'll start here. Just some disclosures. I don't have any financial disclosures to report. I will say that some variation of this presentation has been presented. It came about first in a publication in 2020, which I'm happy to forward to you all, or if you can find it, great. And that is when, sort of setting the context, that's when I really started thinking, wow, we do not talk about this at all. And I was a psychology extern at the time, working at a hospital. And so we were seeing, a lot of death, as many communities, as maybe many of you have as well. And we're just seeing all these overdoses. Again, the rise in overdoses really kind of started in 2013-ish. So at that point, there has been some years that we've been seeing this. And I felt it. I felt it in every room that I entered, and there was this sort of grief. There was this recognition of how much and how many people we've lost over the years. And at the time, again, as a trainee, I didn't really feel like that was talked about, and it certainly wasn't validated for me. And we can talk again at the end if others have had similar experiences or different experiences. But I noticed myself kind of wondering, okay, this is happening. Is this real? Is this real for me? And that's where that paper kind of came about. I started really researching and trying to talk to other peers and other colleagues around, like, is this happening? And collected basically some literature. Really, there's not a lot, as you'll see today, but collected some literature in the fields of suicidology, as well as just general bereavement and general grief literature, and sort of started trying to piece these things together for our population, for the providers who work with people who use drugs, for providers who work with people with substance use disorders, because we're the ones that are seeing this loss sort of front and center. So that was the original article, and then since then, I've been very lucky and very privileged to give several presentations on the topic, like today. So you'll get a snippet of that today for sure. Most recently at the New York State Psychological Association's Addictions Division Conference. And a colleague and I are preparing a chapter. So it's going to be a more in-depth chapter that's going to be included actually in the Routledge International Handbook of Drug-Related Death Bereavement. So for any of you who are interested in, again, drug-related death bereavement specifically, this book is scheduled to be released sometime in 2024. So we're almost done with the editing process. So those are just kind of my disclosures. So why talk about this, right? So this is the number, right? Like this is the number that we're looking at here. 106,699 people who died of a drug overdose in 2021 alone, right? So this is just 1 year that we're looking at, which is an unfathomable number, and has surpassed every number before it in terms of the rates of overdose deaths. And why is this significant, right? Because again, it's an insane number. But also thinking about all the different years that we have experienced this and how the overdose epidemic is in fact getting worse. We're seeing a continued rise. I don't believe the 2022 numbers are released by the CDC yet, but I imagine it's not looking great. And this is across the nation. Of course, some states have seen higher rates than others based on things like policies and drug markets and things like that. But it's sort of across the board, we're seeing a lot of death. Again, just another sort of visual that I think is incredibly powerful, and just seeing the rise. And as you see on the slide, the drug overdose deaths have risen 5-fold over the past 2 decades. And you see again, the sort of, it starts to become steep around 2013, 2014 with the entry of non-pharmaceutical fentanyl into the drug markets. What do we know about drug-related death bereavement among clinicians? Well, spoiler alert, not much. So there's actually very little research, so there's scientific literature out there around drug-related death bereavement among clinicians. But there is some, and I ask you to notice the dates of my citations because it's all very recent. So these conversations that we're having right now are very early. And when we get to the recommendations, of course, one of the recommendations I have is we need to have a better and stronger understanding of drug-related death bereavement among clinicians. But so far, what do we know? So we know that different providers are impacted, right? So I know I use the word provider sort of loosely, and that's intentional. There's some evidence that psychiatric providers, so psychiatrists and residents, so psychiatrists in training, are impacted by drug overdose deaths, and particularly bereavement. We know harm reduction and peer workers are impacted as well. And I want to make a note around harm reduction and peer workers, which I'll make again later on. But thinking about providers' various roles in their communities, right? So of course, yes, provider is a provider is a provider. And I'm sure in this room, there are many different kinds of providers. But some are much more involved in their community. So peer workers, for example, right? They're peer workers. So they're not only providers of mental health care, they are also members of their community and often interact with their participants and their clients in different ways, whether they go to church together or, they're related. There's sort of 6 points of separation. And we can think about, the impact of bereavement for folks who have sort of multiple relationships with their clients or their participants. It's obviously going to exacerbate grief, exacerbate bereavement and complex bereavement. There's just something to keep in mind, again, as we go. But there is literature about this already, and you see 2019, 2013, right? Very recent stuff. We're seeing a range of grief-related reactions. So in again, the few articles that we have that assessed sort of how providers are dealing with drug overdose deaths of their clients, we're seeing sadness, guilt, anger, helplessness. We're also seeing nightmares, flashbacks, self-questioning, anxiety and frustration, feeling devastated, exhausted, and demoralized. We're also seeing a reduction in empathy, which I thought was really interesting. It's again, very recent article by Winstanley in what they dubbed overdose-related compassion fatigue. So most of us may be familiar with the idea of compassion fatigue, or even sometimes it's called sort of vicarious trauma. They're slightly different concepts, but this idea of compassion fatigue, right, is like we practice obviously we have such an important job, but that can be so emotionally tolling to have compassion, to have empathy, right? And so what that sometimes results in, if there's not adequate supports, is compassion fatigue, right? So more similar probably to burnout. So when Stanley discusses the same concept, compassion fatigue, in the context specifically of overdose-related compassion fatigue, which is really great because there's, again, A, we don't talk about it, and B, we don't have really like terms for it. So what are the barriers to bereavement among providers? The way I like to think about it and the way I'm going to talk about it today, there's sort of two main barriers to bereavement among providers. So one is the nature of the death. So the nature of a drug-related death or an overdose, and the other being the nature of our jobs, the nature of being a provider. So let's talk about the nature of the death first. So what do we know about, again, drug-related deaths or overdoses specifically? They are qualitatively different from other deaths because they are a sudden death and they're an unexpected death. We know that there's a perception that this death is self-inflicted and avoidable. So certainly there's some debate around the substance use, right? An overdose requires a behavior, substance use. And again, many of us who work with people who use drugs or people with substance use disorders understand that there's such prevalent stigma that comes with substance use. And so death related to substance use or caused by substance use is also seen as self-inflicted and avoidable. Again, many of my colleagues in the field, clinicians, have seen or heard the words like, oh, well, that was bound to happen, quote unquote, right? Or they had it coming, quote unquote, which are just devastating statements. And you can imagine, how they do not help, but in fact, again, serve as a barrier to the bereavement process. There is ambiguous intentionality. So again, I've heard some conversations around sort of like an intentional overdose, which is often sort of counted as a suicide versus an unintentional overdose. My take on it is that the rise in overdose deaths that we're seeing are largely unintentional overdoses. They're accidental overdoses. But at the same time, the prevalent myth in the field sometimes is that we're not really sure, was it intentional? And we can't know. So I think that sometimes also serves as a barrier to healthy and functional bereavement. Stigmatized prerequisite, right? So I mentioned this just a few moments ago, but an overdose, the prerequisite for an overdose is drug use, right? So drug use is highly stigmatized in this country and elsewhere. And so, of course, the death itself, stigma sort of crosses the boundary between life and death here, where the behavior, even when the person is alive, is stigmatized and continues to be stigmatized even after death, which again serves as a barrier to healthy bereavement. And for all of these reasons, overdose deaths or drug-related deaths are often called a marginalized death. And this is a term that was coined by Valentine and Bald in 2016. And it's really a beautiful and accurate term. So this is a death that is not sort of seen. It is not accepted. It is not a noble death where somebody maybe struggling with a chronic health condition or fighting, for example, we hear language around cancer, right? It's a battle with cancer. But overdose deaths are not seen that way, right? They're not seen as noble battles with substance use. They're often seen as, again, all of these things that are self-inflicted, avoidable, sort of stigmatized, and in such they are a marginalized death. Other types of marginalized deaths we can think about, well, it's not just we can think about that, but Valentine and Bald also reference things like deaths related to HIV and AIDS, deaths related to gang violence, right? So again, these are sort of stigmatized deaths, deaths that we don't consider noble and therefore don't have room for to discuss in the way that we tend to maybe discuss death and as we'll see, bereavement as well. So changing topics to sort of bereavement, right? So what do we know about overdose bereavement? So we know that it does come with a lot of guilt, relief, shame, and stigma. So this literature is really interesting because we don't know much about overdose bereavement among providers yet. So the bulk of this literature actually comes from overdose bereavement among family members. So you'll see a lot of sort of the same names in my citations because there are groups, there are research groups that dedicate their time and their research to understanding the needs of family members who have lost somebody to a drug-related death or an overdose. So most of this literature is coming from those groups studying this. There is a sense of unworthiness to grieve, right? Again, related to this marginalized death, sort of a marginalized death leads to the sense of, well, I can't grieve it. I can't grieve it properly because it does not deserve to be grieved in the same way as, again, a more noble death. And this is what we're seeing again across family members. Seeing a lot of judgment and a lot of pity. And this is among people who have lost loved ones to overdose, but also from others, right? So there's sort of self-judgment and self-pity. Then there's also a lot of judgment and pity coming from society, peers, even the healthcare system a lot of the times in these studies. So that's something that comes that is, again, qualitatively different from other types of death and other types of bereavement. Folks who have lost somebody to an overdose or drug-related death are often deprived of social support and meaning making. Now we know meaning making, so which is quite literally like making meaning out of something that is tragic or traumatic, is such an important part of healthy grief and healthy bereavement that when folks are deprived of that process and cannot adequately make meaning out of a death, it really turns from healthy bereavement and healthy grief to what we would call more complex grief or complex bereavement. right? And as such, we talked about the marginalized deaf, but the grief around overdose bereavement is really called a disenfranchised grief. And again, this term was actually coined earlier than the marginalized deaf term by Doka in 1989. And similarly, it's a grief that is not recognized. It is a grief that has no place, that people don't know what to do with, that often people don't feel comfortable discussing or feel, as you see in the second bullet point, unworthy to grieve. So that's the nature of sort of what we know about overdose and drug-related deaths and bereavement in general. And then where do providers come in, right? So as I mentioned, the second barrier to provider bereavement is the nature of the job, right? And this is where I think we can really get into a discussion after I go through the slides, because this is where I get a lot of feedback usually. So the nature of our job. So there is a general kind of human heightened aversion to acknowledging our own and others' finiteness, right? So while, yes, we are all providers, or maybe many of us in this room are providers, we are also human beings. I feel like there is a general, particularly I will say in Western culture, there's an aversion to talk about death. It's awkward. It's, people get uncomfortable because it does require acknowledging other people's sort of finiteness or even our own. So there's anxiety about talking about death in general, let alone talking about our own grief or our own experiences of bereavement. There's a lack of training on death, dying, and grief. Again, I was trained as a clinical psychologist. I did not have a class or course on death, dying, and grief. So anything that I learned about bereavement or just death and dying, right, not necessarily just grief, but just the, again, very natural process of death and dying, I learned outside in sort of in spaces such as this, right, or just kind of additional continued education as opposed to as part of my clinical training, which I think is huge, because again, death and dying in and of itself, maybe not even necessarily related to overdose or these kind of tragic marginalized deaths, but death and dying as a whole is, something that we're all going to experience and we're all going to see, whether in our personal lives or professional lives. So the fact that clinical training programs do not provide training on this most foundational aspect of human life, the end of it is it's pretty ridiculous. So that's going to be obviously a part of my recommendations later on. Institutionalism. So the hardest thing, and again, I mentioned that when I first started thinking about this topic and started writing about it, I was a trainee in a hospital. I'm still in the same hospital, just FYI. And I noticed, particularly in this institution, there was so much administrative workload that came when a client died of an overdose. Almost immediately, there's all these things. There needs to be a chart review. I'm in New York State, so New York State, you have to fill out like a bunch of different forms and submit them to a bunch of governing agencies. And everything has to be done within, a certain amount of time. And that's a lot. I mean, it's not just that it's a lot administratively, but it's a lot when we're talking about having just lost somebody potentially very important to us. And so sort of the administrative hassle that comes with it is how institutions often address this, right? When we think about like, oh, what happens if a client dies? The answers tend to be very administrative. Oh, you do this, you fill this out, blah, 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 blah. And that's a piece of it. But again, it completely, it creates another barrier to bereavement, right? Because that's another thing that we have to do, that we have to focus on. Fear of litigation has always been there, and this really comes from the suicidology literature. Providers have often been sued by, family members of folks who have completed suicide. So that fear of litigation has sort of emerged from that literature. And again, suing the provider, and again, from the suicidology literature, suing the provider is often an attempt to cope, right? An attempt to get answers, an attempt to get out anger, place blame. So it can absolutely be a healthy part of grieving, but certainly for the provider, it's terrifying, right? We have our licenses, we love what we do, and so of course being sued is not something that any of us want. So there is that fear of litigation as well. And did I chart everything correctly? And what's going on? What's going to happen? How do I protect myself? How do I protect my job? And the pressure of competence. So again, I keep mentioning I was a trainee, and I think literature suggests that trainees are actually more vulnerable to sort of feeling the impact of client death, regardless of the cause of death, because they are, younger, they're tend to be more anxious. I know I was. And there is that sort of pressure of competence, right? There's a pressure because you are evaluated, you're in training, you are supervised, and you want to be good. So at that point, right, when you lose a client, and again, particularly to overdose, which is what we're talking about here, there's a sort of pressure of like, what did I do wrong, right? What did I not do? Should I have done something? Should I have done something better? And what does this mean? Are people going to trust me with clients? So it can get, particularly again, trainees can really be quite harsh on themselves. So one of my recommendations later on will be to really focus on supporting early career professionals and trainees who might be slightly more vulnerable to these barriers and to even sharing their experience. There's a lack of professional guidelines on bereavement, right? We don't know what to do. We have, depending on what provider you are, you certainly have ethical guidelines, right? Trained as a psychologist, I have the American Psychological Association, I have NADAC, right? Like I have all these different codes of ethics available. But when it comes to bereavement, questions like, do we hold them? Can I attend the funeral? Can I contact the family? Should I contact the family? Should I hold the family session? Can we disclose to the groups? What if what if other clients already know? Can they disclose because HIPAA? And so there's just like all this sort of vagueness around what can we do, what can't we do? And right now, because of a lack of guidance or sort of official guidance or recommendations, we're often stuck doing what we think is right. So we have these discussions with our peers, we have these discussions with colleagues, and then we take it from there. So that's sort of where we end up. The intertwined personal and professional lives. So I mentioned this earlier with regard to peer workers particularly. And again, peer workers are really a wonderful example as providers who are also heavily intertwined with their clients and their participants in personal lives in their communities. So that's really what I'm talking about. And that's another barrier to bereavement because it creates more complex grief. You're not just losing a client, you're not just losing a participant, you're also losing a community member, potentially a friend, potentially the guy you see at the grocery store, somebody who may have been close to you, may have been important in your community in other avenues. Remnants of the blank slate. So I don't know how many psychoanalysts are in the room, but certainly in psychology, we've moved past this, but back in the day, and again, in more psychoanalytic circles, there's the idea that the therapist serves as a blank slate, right? That the therapist is sort of doesn't exist as a human per se, but really is there for the client to sort of project anything onto the therapist. And while certainly the field of psychology, the field of psychotherapy has moved towards a more two-person, more relational perspective of psychotherapy, and recognizing that, like, hey, the therapist is indeed a person with their own emotions, with their own reactions. There's still something, of a remnant that I think is permeating the field when it comes to the blank slate, when it comes to self-disclosure, for example, right? I'm sure many of us have been in conversations around self-disclosure and what do we disclose and when do we disclose it and why do we disclose it? And the same can absolutely be said for bereavement. In fact, I'm going to pull up a quote from a wonderful book on bereavement among actually providers. And I think it speaks to it just so beautifully. We may be inhibited by feelings of shame, as though having strong feelings for our patients is taboo. We feel bereft, but unlike with any other loss, the world may not recognize that we are mourning. And again, in the book, the author is speaking to losing a client due to another cause. So they were certainly not talking about drug-related deaths or overdoses at that point. But this idea of having strong feelings or acknowledging that we have strong feelings for our clients, that I see quite often. And I think it was actually that that contributed to my own difficulties as a trainee. When I was walking around, I was like, is this real? Is this real? And I think it's because it was so taboo to discuss that, hey, this hurts me too. Seeing clients, lose their community members, lose their friends, that has an impact on us too. So particularly, that's what really drove me to start having these conversations, because we need to talk about this. We need to not have it as a taboo any longer, which is why we're all here, and hopefully that's why you're here as well. What do we do with all this, right? So we've identified the barriers. There are many, but what do we actually do with this? So I have a series of recommendations, and again, this is just based on what we know so far. So of course, the first recommendation is going to be further research. We need to better understand, because I'm speaking, the few papers that we have on providers' experience with overdose deaths, but a lot of it is really, again, coming from suicide literature and the family member loved one literature. So while we can make maybe some assumptions and draw some parallels, we're not going to actually know what providers are needing or what supports they're wanting until we have better conversations and more research to help inform those kind of individualized and context-specific recommendations. For example, we don't know the differences among different providers. Somebody who, again, is a peer worker and somebody who is a psychologist versus somebody who is works for the EMS, they might have completely different experiences, and they have and needs when relating to drug-related death or drug-related death bereavement. More compassionate approach to substance use, right? So I think there's a good audience here, because what we really want to do is try to interrogate stigma and encourage discussions around both substance use disorders, and drug-related deaths and overdoses, right? And we saw just how prevalent stigma is as a barrier to bereavement, again, for family members and for providers. We do know this. So in order to get at that stigma, we really have to have more compassionate discussions around substance use in general. Comprehensive guidance for drug-related deaths, right? You just heard me say that. We don't know what we're doing. We're kind of going off of what our colleagues are doing, and thank God we have those colleagues. or what sort of whatever guidance that we can find online, and going off our gut and our sort of ethical values that we do have. But at the same time, comprehensive guidance can be incredibly helpful. And I'm not talking that this has to be on the federal level. It can be just your system. If you're in a group practice, your group practice. If you're in a hospital-based, some kind of guidance, even if it's just you in private practice. But something to help you feel more prepared and also to prevent that kind of chaotic search of like, what do I need to do? What's the guidance around this? Again, at a very vulnerable time of that initial loss, that initial grief. So having some, again, even internal guidance around this, I think would be incredibly helpful. Institutionalize a well-being. So I write institutionalized because I debated talking about sort of self-care, right? So we know self-care works, right? Talking to colleagues, having a nice work-life balance, things like that. Absolutely do that. If you do that, great, keep doing that. It's incredibly important. And at the same time, I didn't want to just leave it there. I didn't want to just say, hey, you might have experienced a lot of loss, but get your nails done and take a bath and everything's going to be okay. Really, what we need to do is start having discussions around institutionalizing wellness. And that means thinking about the institutions that we're in, again, be that hospitals or group practices or community mental health, wherever you're at, and looking at the policies. Our staff given opportunities to discuss, if an overdose death happens, is there space for that? Are there mental health days sort of accounted in the policies of like with vacation days and things like that? Are there days specifically for bereavement, and are staff encouraged to use those days? So really looking at the policies and the structures of your environment and seeing like, is this wellness oriented? And starting to interrogate, maybe if you feel comfortable, starting to have conversations with colleagues or leadership around how we can really integrate wellness into the culture of our environments and to the culture of our institutions, rather than putting it all on individuals to take care of themselves, after 5 or 6 p.m. Before that, you can't take care of yourselves, right? Because that's not working. So that's that. Implementation of peer support. So, this could be supervision. This could be peer supervision. I look particularly towards my folks who are in private practice or independent practice, who have less and less safe spaces to discuss anything, right? And particularly when it comes to overdose deaths, of course, because there's not a lot of safe spaces to discuss this at all. But I also here speak to kind of informal mentorship programs or mentorship setups, because it doesn't have to necessarily be a formal, evaluation-based supervisory relationship. It's not about that. It's really about having that peer support, but integrating it in a way where it's accessible and it's consistent and it's available for when and if we need it. Again, I use the word here intentionally. And I think a lot of this, a lot of the structural changes that I'm recommending or, wanting to have more discussions about are all about being intentional in our practices and being intentional in our changes. Training on death, dying, and grief, right? So you heard me mention this earlier. Even during my doctoral training, I did not have a class on death, dying, or grief. And I feel like having that training, particularly early on in somebody's career, can help providers become more comfortable with the topic. And again, I'm not just talking about drug-related deaths here, right? Like this is a very specific conversation that we're having, but just any conversation and any training around death and dying, because it's such a natural process, that providers, I think, absolutely need to be aware of and need to become more comfortable talking about, as well as potentially interrogate their own, or as us in this room, our own thoughts about death and dying, certainly our own cultural um, uh, socialization around death and dying, right? What that means to us, and what does grief look like? What does grief look like in our culture? And just, again, having a space to have those thoughts and to have those discussions. I think that's all I have in terms of recommendations. Well, reduce overdose deaths, of course. I knew I put that there. It's sort of,
Adelia, there was just a question about this slide that came in. Somebody asked if you meant professional peers or mental health substance use disorder peers in recovery.
both, certainly both. And depending, I know I probably have a lot of folks from different states, and I know different states use different language around, sort of peer recovery coaching, things like that. When it comes to number 5, the implementation of peer support, here I really mean like peers and like colleagues, like we are all here as peers. And so that kind of peer support, if that makes sense. Yeah, I know, sorry, I keep using the same word in different contexts. Megan, does that clear up the question? Okay, perfect. And if we want to clarify, we can do so in a couple of minutes. But yeah, reduce overdoses, right? And in giving this presentation, I always say, like, I don't necessarily want to have this conversation, right? I don't want to talk about how to grieve better, because I don't want to grieve anymore. I don't want to lose any more people. I don't want to lose clients. I don't want my colleagues to lose clients. So I think, of course, first and foremost, we do want to curb this unprecedented death rate, which comes with a slew. That's a whole other presentation, right? It's to focus on harm reduction practices and be knowledgeable around sort of overdose prevention, naloxone, certain service programs, overdose prevention sites, like all of these wonderful things that are happening in our country to try to curb this unprecedented death rate. And as providers, we can be on board with that, and we can be a part, and we should be, and we often are a part of those larger efforts. And I always like to close this this presentation with a quote from a colleague, actually, when we had a presentation like this, I think it was last year. And it was a structured discussion that I was moderating. And this is coming from Michelle Mathis, who is a wonderful harm reduction worker based in North Carolina. And I asked Michelle, and I was like, how has this rise in overdose deaths affected you, affected your community, affected your staff? And Michelle said, as you see on the slide, some days it's why I do this work. Other days it's more like, why the F do I do this work? And I close on this note because it's also just an acknowledgement that this work that we do as providers is really hard, especially now with where we are again in the overdose epidemic. And while it's hard, and there are absolutely days where we ask ourselves, why the F do we do this? There is also resilience there, and some days it's why you do this work, because we do have this power, and again, seeing the resilience among community members who have lost so much over the last few years is a huge driving factor. And some days it's not, and some days it's absolutely devastating. And other days it's incredible to see people who continue to advocate for their communities, for their clients, for their participants, all the way, to the federal level and beyond. And so I want to sort of acknowledge that there are good days and bad days. So that's that, and I'm happy to have, this is perfect. So next, I guess, 15 minutes or however long we have for questions, and hopefully I'll have some answers, if not all.
Sure. Sorry, I had to get my, so I can
No,
go
no,
through.
no worries. Can I stop sharing? Would that be
Uh,
easier?
if you want to, or if maybe if you want to keep your contact information up for a little bit, just so
Oh,
people
that's
can
true.
see that.
Yeah, I can also.
Um, Georgia just messaged, thank you. Agree with your statement. My sister, unfortunately, is a part of these statistics as she overdosed, not intentional. It's so heartbreaking to me.
Yeah. Sorry, Georgia, for your loss.
Then Courtney said, I get this. I feel we are in the trenches of a health crisis.
We absolutely are, Courtney. Trenches. And we've been in the trenches.
So, and then there were a few other comments earlier, when you were talking about the deaths for 2021. Somebody commented that per the CDC, there's an estimated 109,608 deaths projected for 2022, unfortunately. And then somebody commented with the phrase it's a non-casserole disease, which I know I've heard before about how, people bring casseroles over when people die in certain ways, but this isn't one of them.
Absolutely not at all, right? And again, thinking about that really, I haven't heard that, but as soon as you said it, it made complete sense to me. Yeah, we don't treat it the same way. Absolutely.
Um,
Um,
oh, go ahead. I'm sorry.
no, I saw the question about the book name, so I was trying to find it. So I'm gonna post the book, the quote that I took from Edelman, 2013. So I'm gonna post it in the chat. Um, that's what I was gonna do. It's called The Therapist in Mourning.
Thanks for
Hopefully people
posting.
can see that.
So Bonnie asked a good question. She said, is anyone else angry about this and who should we be angry with?
Oh, Bonnie, yes, I'm angry all the time, and it depends on the day. Um, I mean, Bonnie, who are you angry with? I guess I almost want to throw this question back.
No.
Can people speak, or is it just chat only here?
I don't think we have the ability to have attendees speak.
I just
Um,
wanted to check, yeah, because
yeah,
but I
but
see Bonnie answered. Big
yeah.
pharma doctors, therapists. Yeah. Um, the unregulated poison drug supply. That's one that I'm angry at often.
Mhm.
Uh, I see a question from Courtney. I have been noticing more obituaries from families disclosing the person's struggle with substance use. How does everyone feel about this? And yeah, I encourage other folks to chime in. But I think it's meaningful, right? Because often people do not or historically, right, as we saw with the marginalized death, people do not disclose. In fact, a lot of the literature from the family member's perspective shows that people actually will lie and say that it was an accident or give some other cause of death because of this shame. So in that way, I feel like it's incredibly brave and courageous for family members to share and disclose a person's struggle with substance use. The flip side of that is, does that open up more space for shaming or stigma or prejudice, things like that? So as always, it's a double-edged sword.
Mhm.
Um,
I think stigma is still so, like, stigma within the community. I grew up in a small town in central PA, and there was recently a post on a community page there about free Narcan, and so many people had just negative comments about
Mhm.
saying people shouldn't be able to get Narcan because it's their fault, and also, you know, they bring in the argument about, well, if this is free, why can't I get free diabetes medication? And it's just this displaced, you know,
Mhm.
displaced blame.
Absolutely. Right. No, I often hear that too, right? It's like, why should naloxone be free when other medications are, and this sort of, yeah, lateral violence, right? And thinking, trying to compare different conditions and things like that. When, to Bonnie's point, maybe we should be angry at big things or sort of greater systems that are beyond us.
Right.
Um,
Megan had a
yeah.
good comment. She said, we each have a responsibility to decrease the stigma of substance use in our communities. Take the casserole to the grieving family, talk about it with your colleagues, express your sadness.
Absolutely, absolutely, Megan. I agree with that 100%. And that's again, this is for me, that's what started this whole thing, right? Is not having a space or not feeling like I had a space to talk about that or to acknowledge it and feeling weird about that, like genuinely feeling weird about expressing my sadness. Like it felt very taboo, as I mentioned. So we do in that way, hopefully we have a responsibility, I think also like to ourselves, honestly, like to the family members. Yes, I think Shelley mentioned, it helps the families to know that their loved one was missed by the provider too. So in that way I could see, having responsibility to the family members, but I think mostly for ourselves, for our own self-care, for our own healthy grieving process, we need to be able to talk about it, because we do care. And if we're provided, if we went into this field, it's not because we don't care. Um, all of us.
Giselle asked, and is there any info regarding death of colleagues who have a recurrence and overdose, or if you have any experience with that?
Yeah, absolutely. Some of the peer and I believe you'll all get this the copy of the slides. So I believe a couple of citations that talked about harm reduction workers really speaks to that. And there was one, and I'll make sure it's in there for sure, Giselle. There's one very powerful paper that was written a couple of years ago that speaks to sort of the harm reduction movement and constantly hearing like these people who, know everything there is to know about overdose prevention, know all the tips and like, have all the supposed support, and yet are still dying and who like work in the field because they're either returning to use or they're, of course, falling victim to things like fentanyl. So yes, there is, again, there's two papers that I can think of that speak specifically about colleagues. So there's not a whole lot, but I'll make sure that those citations are included in the presentation that gets sent out.
Thank you. Emily had a good question. What if colleagues or anyone in general do not wish to talk about it?
That's fine. That's a choice too. I think it's um, an excellent point, right? Because we want to respect that, and again, we want to respect colleagues' own personal experiences with grief, personal experiences of, death, experiencing someone's death. What I'm advocating for is creating a space for those who might want to. Um, but yeah, I wouldn't like force a process group or anything like that for people who don't. Um, Also, healthy grief can look differently, right? There is no, I mean, we have sort of stages of grief, we have all these models of how to understand grief, but grief is going to look differently for different folks. And if somebody has, the resources and they're kind of not talking about it with their colleagues is the way that they're handling it, fantastic, right? We want people to have options, but that's the idea. We want people to have options. Others might not have those options.
And Emily had elaborated and said, I think some providers may need to compartmentalize in order to do this work, so they typically do not like to discuss the loss at all.
Sure. And again, the thing about compartmentalizing is one has to be curious around, like, is that adaptive? Is that maladaptive? Is that helpful? Is that not helpful? If it's adaptive and helpful, again, like, great. And we need to sort of, put that on the shelf to do our jobs, to be more effective. I get that. And at the same time, I don't want to force that. Having options is essentially the takeaway for me here.
Bonnie had another question. Let me scroll up, sorry. Are there any online programs or chats directly related to grief of loss related to substance use? And I'm guessing she means relating to people working in the field.
Yeah, so no. There are in some states, and I'm happy to send out some resources as well. There's some states that will have groups. The groups really tend to go for like family members, right? Family members who have lost a loved one to a drug-related death. But there's not, there's certainly nothing for providers that I know of besides these kind of impromptu conversations that we're having. And there's no like specific hotline or nothing like that for sure. In terms of the groups that are available for family members, my understanding is that they tend to be just very grief oriented. And a lot of folks that we see here, we send them to sort of more general grief groups and grief support programs. But again, that's hard because this is a different type of grief. So whatever resources that I do have, and I have a list somewhere, so I'm happy to. Yeah, I'm taking notes of what I need to send you all. So I'm happy to include that as well.
Sure, yeah. And if you want to send an email to me with those, I'll make sure it's posted on our website with the recording.
Fantastic.
It looks like the comments coming in have kind of slowed. There's still just a lot of people thanking you for this wonderful webinar. And thank you everyone for allowing us to have this great conversation. In these last couple minutes, I'm just going to go over a few housekeeping things. I just want to thank Adelya again for such a great webinar. We would love to have you back sometime. We would like to remind all participants today that a PDF of today's PowerPoint along with the recording of today's presentation will be uploaded to our webinar library located on IREDA's website sometime within the next week. Once we have these resources posted, a link will be sent to all of today's webinar registrants. I now want to remind you all of our evaluation and CEU process. You will receive a follow-up email from us. This will include a link to the evaluation and will also include step-by-step instructions on how to obtain your CEUs. Please note that it will take up to 48 hours for your CEUs to become available on your MyIREDA profile because we have to cross-check your attendance records through WebEx. We would like to specifically request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email address is info@ireda.org. And as you saw, Adelya posted her contact information if you'd like to reach out to her directly. And with that, I will conclude today's webinar. Thank you so much and have a wonderful day.
Thank you so much, everyone. Have a wonderful day.